Okay, I will request the chairpersons of this session to please come and take their seats. Uh, Professor Arif Tajamal is abroad at the moment, so he won't, he might join us remotely. Professor Rubina Hussain, Professor Nargis Sumro is not here, so the panelists are Dr. Naila Siddiqui, who is joining remotely. Professor Shama Munim, is she here? Please come on the stage. I will join shortly. Professor Shahina Zahoor. Professor Luman Sheikh could not make it. Unfortunately, her uncle passed away today, so we will say a prayer for him. Dr. Tehmeena Ali, Professor Aisha Malik, Professor Fauzia Mono. So please, those of you who are present here, please join Professor Rubina Hussain on the stage. I will introduce our Professor Eddie Morris, who is the president of the RCOG, will be joining us as well. But since it's an international link and Dr. Jyotna Acharya is here, so she is in the Royal College, she's a Royal College Council representative for South Asia, clinical lead and consultant obstetrician and gynecologist at Maxfield Hospital in Cheshire, UK. She has a special interest in minimal access surgery, high-risk obstetrics, and medical education. She has been the past international convener for MRCOG Part 3 courses and MRCOG and PLAB examiner. She's going to talk about membership of the Royal College and career pathways in UK for overseas doctors. So can we have Dr. Jyotna, please?
Hello, everyone. Can you hear me?
Yes, we can hear you clearly and see you clearly as well, Jyotna. So we have a room full of very senior Royal College fellows and members, past RCOG committee members. I happen to be one of them. And Professor Rubina Hussain has been the former chairperson of the IRC committee, who's chairing the session right now. And Dr. Shaina Ishtiaq, professor, she's also a fellow of the college, and Professor Shama Monem is also a fellow of the college. She is a fetal medicine specialist, one of the few in Pakistan. And I think we've all trained in UK. So, and in the audience as well, we have an illustrious crowd, and one of the very, very senior RCOG fellows of Pakistan, Professor Emerita Aftab Munir, is also sitting here. We're really honored to have her.
Absolutely. No, it's my pleasure. It's my absolute pleasure to be part of this meeting. I'm really honored to be. And, I took up my post and then COVID hit, as you all know. I took up my post 2 years ago. And I've not had a chance to actually personally interact with any of you. So I'm really honored to be part of this. And I'm sorry for all these glitches. I thought I was all prepared. And somehow that has not happened. So
Dr. Jyotsna, is that you start reading your presentation from your end. We can hear you and see you clearly. So just read off the slides for the time being till we get.
I'll do that. I'll do that. So I've just sent the email through, but I will start reading like you said. So thanks for the kind introduction. Like I said, this is my first opportunity to actually interact with all the Pakistan members and fellows, and like you said, all the senior members. But this presentation is mostly for the recently passed members who, not recently passed, actually for those who want to become members, let's say. And so it's basically telling you about what the RCOG is. So RCOG, like most of you know, It's one of the sort of well-known colleges in the world. And to be a member or fellow of the RCOG is gold standard membership. So the way you can become a member are various. So first one is known to all, which is passing the MRCOG part 1, 2, and 3 examinations, and then gaining membership of the college. Then after about 10, 12 years of senior practice as a member, you can apply for fellowship. And that is another way of, and it's an honor to be a fellow, as you all know. But there are other ways to get some membership within the college. One is diplomat, or becoming a diplomat of the college by passing the DRCOG examinations. And this is for people who are practicing in general practice and are very interested in women's health. The other ways is being an associate member. The associate members are those who basically specialized in obs and gynae, but still haven't passed their MRCOG examination. So it's like a stepping stone. So you become the associate member, you have access to all the material to help you prepare for the MRCOG examinations. And then there's a new one called affiliate membership. And this is for people who are non-doctors who want to be associated with the college. And for example, somebody like an embryologist or a sonologist who's wants some part of the RCOG. So membership examinations I've already told you about. Oh, I can see that my slides are up now. Thank you very much. So the specialty training program, I just wanted to touch upon how somebody becomes an obstetrician gynecology if you are in the UK. So you do foundation year 1 and 2, and after, which is very similar to internship that you would do in Pakistan. And after the internship, you apply for training in obs and gynae. Similarly, here they apply for entry into ST1 level. So the whole obs and gynae training lasts for 7 years, starting at ST1 level and finishing at ST7 level. So first 2 years, which is ST1 and 2, ST stands for specialty training in obs and gynae. So ST1 and 2 are the basic training years, and then anybody who has to go to ST3 has to pass their part 1 MRCOG examination. And then they have intermediate training from ST3 to 5, and at that point, at ST5 level, they again have to pass the part 1 and part 2 MRCOG before they can go on for advanced training, where they would do advanced training skill modules such as fetal medicine, gynecology, and things like that, or subspecialty training like urogynecology or oncology, and then become a consultant after gaining what we call completion of training. Can I have the next slide, please? Thank you. So this is just a summary of what I just told you from that algorithm of how you train. Obviously, the trainees in the UK are assessed each year. That's the final line, which says each year, which is the ARCP. They have like annual review of their competencies, and they have to gain the competencies and show evidence of the competencies. And after each year, they finally, after year 7, they gain what is called CCT, or Certificate of Completion of Training. Next slide, please. So what about the opportunities for people like who want to come and work from Pakistan? So there is a non-training way of getting into UK and working in obs and gynae. So to come to work in obs and gynae, you need to have the full Gmc registration. So GMC stands for General Medical Council, and you need a license to practice. So, and you have to pass the PLAB exam to get the GMC registration. Once you have that, you can apply for what we call locally employed doctor posts, which are advertised from the NHS hospitals. Or you can apply to work as a SAS doctor, which is specialty and associate specialist doctor. Generally, the LED doctor posts are at a junior level, like ST1 and ST2. In old terms, we used to call them SHOs. And SAS posts are mainly registrar level posts, which are again from ST3 to ST7 posts. And when you are working as a SAS doctor or a locally employed doctor, you will have opportunity to gain all the competencies as a trainee would, and then apply for completion of training through the CSER route, which is Certificate of Eligibility for Specialist Registration. So this is another way of gaining entry and gaining entry into the specialist register. Next slide, please. So some of you might think, I want to come from Pakistan, but I want to get into the training system. I don't want to go to the CSER route. So it is important to know that the entry level to training system in Obs and Gynae is at ST1 level, which is the entry level, SHO level, or at ST3 level, which is basically like a registrar, a very junior registrar. And the recruitment process is coordinated centrally by Health Education England. So all the applications go to Health Education England, and then you will get shortlisted and called for interviews. Next slide, please. So if somebody, say, is quite junior, has just done their internship, and want to gain entry in the training system in UK, what you basic necessity is that you shouldn't have more than 24 months of Obs and Gynae training back in Pakistan. So obviously it's not suitable for somebody who's already done this post-graduation. But if you're a junior and you manage to pass the PLAB examination and get GMC registration, then you should be eligible for ST1 entry-level applications. So I would encourage you to look at the Health Education England website to see when the applications are accepted. Next slide, please. ST3 level recruitment, this is for somebody who has, say, suppose, worked in Pakistan and actually trained for a few years in Obs and Gynae, and you are confident that you will be able to work at a registrar level. The prerequisite, obviously, is that you have to have passed the MRCOG Part 1. And you should show evidence of competencies that an ST1-2 trainee would gain in the UK. So these are basic things like doing instrumental deliveries, doing episiotomies, batholysis, and things like that. As long as you have the evidence, then you can apply for the ST3 level entry. I would actually encourage anybody who's interested in applying at ST3 level to come and work in the UK for a year or so that you know the system, you have all the competencies signed off, and then you can apply for these posts. And once you're successful in getting into ST3 level, obviously, then you would pass your exams and then go on to ST6-7 and then can become a consultant in the UK. Next slide, please. So I told you a little bit about the RCOG Associate. So this sort of membership is helpful for people who really want to sit the MRCOG Part 2 and 3 examinations, but have never worked in the UK and would want to have access to all the resources which give you an idea on, how to prepare for the exams. Next slide, please. So to become an RCOG associate, you have to have a medical degree, but obviously you would not have passed the MRCOG Part 2 examination, and you shouldn't be in a UK training post, but you should be working and be interested in women's healthcare and uphold the values of RCOG. Next slide, please. So these are all the resources that you would have access to. So you can have access to the news and updates, guidelines. You can have access to the journal called the Obstetrician and Gynecologist, and a lot of exam questions are from there. And then you can have access to all the e-learning resources for single best answer, extended matching questions. And, for the MRCOG Part 2 and Part 3 preparation, things like governance, audit, and things like that, which are a bit difficult if you are coming from overseas. So it is really helpful. Next slide, please. So there is another way you can actually apply to come to the UK, which is called Medical Training Initiative. And next slide, please. So to come to the UK as an MTI, it's like a 2-year placement that you would have in an NHS hospital, and you can apply for these posts, and it is rigorously assessed by the Rcog MTI panel. And once they sort of match you with the UK hospital, you would have a Skype or phone interview from the UK hospital to see that you're suitable for their hospital. Once you're successful, the RCOG will actually sponsor your GMC registration, and they will also arrange a 2-year visa for you, a tier 5 2-year visa to come to the UK. Next slide, please. Yeah, you were right. Yeah. So obviously you come to the UK, you are expected to start as a junior doctor, but a junior level obs and gynae trainee, and then go on to work as a registrar. And this gives you an opportunity to sit the MRCOG part 2 and 3 examinations. And it's helpful as well, because then you get to know the system. Next slide, please. Yeah. So and then we've seen that doctors who return to their home country, they have new skills and ways of working, which they can then use to advance their own country's health resources. Next slide, please. So just to apply for the MTI post, you would have had to have passed MRCOG Part 1 examination, which you can do in Pakistan, but you shouldn't have more than 10 years of experience in obs and gynae. You should have minimum 4 years, and you should have an English language test. And then obviously your IRC chair or your RCOG fellow will interview you and send the interview through to the MTI email, and you will need 2 references and the head of department reference as well. Generally speaking, it's not a bit onerous task. If you're very interested to come to UK, this is one of the ways to come, especially if you've already worked in obs and gynae. Next slide, please. So this is the website and the email to ask more about. I think they suspended MTI applications last year, but I think it will go underway again soon. Next slide, please. So this is a picture of the trainees who had come in. Next slide, please. So I thought I'll just quickly give you some case studies so that you get an idea of how people can come and work in the UK. So this particular candidate was from Egypt and graduated in a medical college in Egypt in 2005, passed MRCOG Part 1 in Egypt in 2006, worked in obs and gynae for 6 years in their own country. Then they came to the UK on the MTI scheme in 2013, passed their Part 2 while in the UK, obviously not during the MTI, but then applied to another post and then got that post and passed the MRCOG in 2016. And then managed to be successful in joining the training scheme in 2018 at ST3 level. So if you come as an MTI, you can still apply for the ST3 entry. And they managed to complete their CCT and now applying for consultant posts. So a real success story. Next slide, please. Yeah, so this is another person who had come from India after passing their Part 1 in India, did an MTI post for 2 years, couldn't pass the MRCOG exam at that point, but then applied to be a locally employed doctor, and then went on to become a SAS doctor, specialty doctor, and managed to pass their examination and now doing ATSMs, so advanced training skills modules. So this candidate wants to apply through the CSER route for entry into the specialist register so that they can work as a consultant. Thank you very much for your patient hearing. This is my email address. Like I said, I haven't had much chance to interact with you all in these past 2 years, but we can rectify that. And I hope that you will contact me if you require anything at all. And it's been a great pleasure to be part of your meeting. Thank you very much.
Thank you. Thank you, Dr. Jyotsna, for that comprehensive talk. And we will organize a meeting with you just dedicated to this topic with the IRC and the candidates from Pakistan. I think these regular meetings will be very helpful. Okay, so our next speaker is the president of the Royal College. We are really honored to have him with us, Mr. Edward Morris, who is a consultant in obstetrics and gynecology at the Norfolk and Norwich University Hospital, NHS Foundation Trust, and honorary senior lecturer at the Medical School, University of East Anglia. He is currently president of the Royal College of Obstetricians and Gynecologists and vice chair standards at the Academy of Medical Royal Colleges. Prior to that, he was RCOG vice president for clinical quality 2016 to 19 and fellows representative for the East of England on RCOG Council. Mr. Morris leads specialist menopause and tertiary endometriosis services. He has authored over 70 peer reviewed articles, book chapters, and national documents, is a co-editor of the journal Post Reproductive Health and inventor of the website Manage My Menopause. He is globally recognized for his work in patient safety, guidelines, medical device work with the MHRA. He was the inaugural chair of the RCOG Patient Safety and Quality Committee and chairman of the British Menopause Society 2013 to 2015. So we're honored to hear him talk.
In person, pandemic throughout, but I'm really glad I'm able to join you virtually, and I hope you certainly enjoy your Congress. And I really look forward to being able to come and see you sometime soon when all of this is over. So what I'm going to do now is I'm going to share my screen, and I'm going to take you through the presentation I've been asked to give, which is on the role of the RCOG during the pandemic. Now, the RCOG has actually performed quite a few significant roles during the pandemic, but I'm going to summarize them all. When I started as president in December 2019, these were my priorities: to address inequalities in the UK health system, to improve the clinical practice of obstetrics and gynecology, mainly through interpersonal risk assessment and hopefully training in gynae surgery, to encourage the study and advance the science and practice of obs and gynae. That's one of the college's key aims, to digitize the exams and to improve how people interact with the college. But of course, then along came COVID-19 and things significantly changed, including my priorities, which really did have to change quite dramatically. So the immediate needs of the college at the time, and the immediate needs indeed of the public, were information, support, and advocacy. And that's those are the key roles of the college. Now, when you look at the immediate needs of the society, if you look at information first, there was a huge need for guidance. And this was something I personally identified very early on, that both clinicians and governments needed that information, but also the public needed it as well. There was a global thirst for countries with COVID to share their information so countries without could get to know about it. And obviously the first two countries affected were China and Italy. There were also tales from the front line given by the media to the public and everyone in general. But also I felt that as president, I needed to communicate significantly with the membership. In London, we first started hearing about things in January 2020, and it was in February 2020 that the first early papers were coming through on COVID and pregnancy. And so I decided to form the COVID guidance cell. And indeed, with a small group of people, we wrote a skeleton outline of the RCOG COVID guidance. And then I wrote version 1 with 3 clinical fellows, and then lots more literature searching. And the first live RCOG COVID guidance was on the 8th of March. Now, we formed a guidance cell that had clinical fellows, senior clinicians, a team from the RCOG, but also other colleges, the Royal College of Midwives, the obstetric anaesthetists, the Royal College of Paediatrics and Child Health, and of course, our women, our users. The pace of work was insane, and I know you will have experienced that in your country, many sleepless nights, days working in a row for weeks and weeks. But that was also keeping up with the demand of the changing information so that we could change our advice and make sure it's up to date. This is a picture of the first guidance. And we're now on version 15, actually. This slide was produced a few weeks ago. We've now released version 15. On the website still, we have the COVID-19 Information Hub, and that's based on all the areas of women's health. So that's pregnancy, gynae services, supporting people in the workplace, but also education, training, and CPD. Now, if you go to maternity, it's broken down by all the areas, and they're all kept up to date. So if there's anything that you needed about COVID-19 and pregnancy, and indeed women's health overall, then it's all there for you to have a look at. We had to have a big media push, putting our spokespeople, so that's Vice President Joan Mountfield and Christina Ketchy. They did a lot of work speaking to pregnant women through the media. I also did some, but quite often the TV program shows want to see women, which is completely understandable, because that's a way to really reassure people, a woman talking to women. But this is immensely popular, and we used a lot of social media at the time. This is one of my proudest moments. The Prime Minister in the UK sent a letter to every single household in the UK, and a page that I've highlighted here, that they actually noted that we have provided helpful information and advice for pregnant women on our website. It was a huge honour to be recognised by the Prime Minister. The guidance has had enormous reach. I mean, in the first 6 months, you'll see that whilst the UK accounted for a lot of the traffic, much of the other website traffic came from India, the Far East, and indeed your country as well. So you'll see that there's a lot of traffic coming our way. And we have become the go-to place for pregnant women and their carers to get the information. We've never been able to measure things in their millions in terms of college work. And with 6.5 million people visiting our COVID-19 hub, in fact, it's very close to 7 million now, you can see that this has been vital to the healthcare community. I've communicated with you. I've written blogs every month, because I think this is really important to keep my members and fellows up to date, not only with what's going on, but also with how I'm thinking. I share your thoughts, and I've also received your thoughts as letters. And so sharing those with you, I think, have been a vital part of the pandemic. And as you know, I produced an international version so that you also get a feeling of how we can help our members around the world. As well as support and information, advocating for women, advocating for doctors, making sure that PPE is right, and things like that has been pretty important for me. And when we look at the very early stage of the pandemic, for women, we had problems. Water births were stopped, home births were stopped because there weren't enough staff, partners were stopped from attending the birth of their children. And these are all really important things to make sure that if there was no evidence to support those things, then actually we could turn things around and say, actually, women need to be allowed to have their partners at the time of birth. Just imagine that, you know, you're the father or the partner of a woman having birth, and you can't be there. That was to the hub. The stories that we heard were quite something. For staff, there were worries about protective equipment, definitions of aerosol generating procedures, what was a high-risk environment, cesarean sections. We ran out of protective equipment in the UK at one point. Redeploying staff away from maternity to the rest of the hospital. We felt that was a real issue, because we don't have a big workforce, and moving them into other areas of the hospital was a risk. But also staff areas in hospitals was enough space for social distancing. I also had to advocate for women with benign gynecological conditions, so prolapse, incontinence, menorrhagia, pelvic pain, severe endometriosis, and so on. Not cancer. Cancer surgery largely carried on. A small hold-up, but nowhere near the hold-up of benign gynecology. The dark blue countries here, in the first 12 weeks of the pandemic, pretty much stopped delivering benign gynecology, and I will cover that a little later. So advocating in the UK has been through various routes. I've done a lot of work with governments, ministers, members of parliament, parliamentary committees, and the chief medical officers. But also we've used the media, patient groups, medical regulators, the British Medical Association, and also the Academy of Medical Royal Colleges. That's the institution that brings all the colleges in the UK together. Supporting people during the pandemic, well, that's really important. And actually, that's mainly for members keeping their careers on track. So we've had to make our education online. We made it free to access in the early stage of the pandemic. We also had to make sure that medical students could continue their training as well. This was a very important thing in our view, that if medical students could carry on being trained, then we could keep going with the doctors of the future. Our events. So here I am speaking to you at a webinar style at a conference, and this is again something that we needed to do frequently. We changed our World Congress to a virtual one. We had 3,000 delegates from 85 different countries. We still had 240 sessions, and we had social media content from all around the world, and it reached millions of people. My favorite moment was that I was sitting in a session, and during that particular session, there was someone in their clinic in Nepal, and there's also someone in their clinic in Bangladesh at the same time, commenting and speaking in the chat about their experiences relevant to what was being talked about. And that to me was amazing. It meant they could afford to be at the Congress. They didn't have to spend money on flights, travel, accommodation, and the Congress. They could just spend money on the Congress, the price for which we reduced significantly, so that we could really spread the education. And I know that you appreciated it. Many people wrote to us. Exams, again, they changed. They had to change. I already wanted exams to be converted to digital, and I'd already started the process in the UK. I'd managed to set up a contract with an exams delivery company called Pearson VUE, who you will know of because they work in your country. And since the pandemic started, we've been able to convert our Part 1, Part 2, and the DRCOG to online completion through the Pearson VUE exams. And that has taken a lot of pressure off. We're still working our way through the backlog because it was a huge backlog that built up quickly, but nonetheless, we are doing so, and we're bringing it to the countries of Asia in particular. The Part 3, that was harder. Doing a clinical exam digitally is a difficult thing to do, but nonetheless, we've managed to get through this. It is a challenge. It needs a lot of staff resource to deliver an exam digitally, to make sure the exam is secure and there's no evidence of any cheating, because that's a very important thing to do. You can imagine someone sitting in their home, the temptation to cheat is quite high, but we've managed to get around that, and we now have a fully remote model. As to what happens in the future, we're undecided. There's still value of face-to-face exams. But now we're in a later phase of the pandemic, and the phases are really about restoration, vaccination, and planning for the future. And this is what I'm going to talk about. First is the restoration. I mean, if you look at the first 6 months, the impact on the UK NHS and on health systems around the world was huge. Between 1.3 and 1.5 million fewer people came to hospital in the first 6 months. There were nearly 2.5 million fewer outpatient appointments. There were well over 250,000 fewer urgent cancer referrals, and about 40,000 fewer patients starting their first treatment for cancer. And those are significant impacts, and they take a long time to recover. Visits to the emergency room, they fell off a cliff. They've slowly got back to normal, and in fact, the winter we've just been through, they exceeded previous years. Services have also needed restoration, and we've written a lot to guide our fellows and members about how to prioritise patients, who should be operated on before others. It's a difficult thing to go through, and the NHS in the UK needs a lot of help in this area. But vaccination is key, and I feel very strongly that whilst in the UK we have had a vaccine from early on, we need to address the issue of global vaccine equity. The delivery and the spread of vaccines internationally has been inequitable, and it's been fueled partly by vaccine hesitancy, but we feel with the UK experience around education, we have a lot to share. But we set up in late 2020 a vaccine development subgroup, and that was all about information to women and healthcare providers, making sure that we were collecting the information on pregnant women receiving the vaccine, but again, advocating for pregnant women, making sure that pregnant women were in vaccine research. But the problem is that a lack of clinical trials in pregnant women led initially to hesitancy in our government to recommend vaccination. And we had to lobby hard to eventually get that advice turned around to a strong recommendation, and now really guidance that women should be vaccinated when they're pregnant. Most women now have probably already had a vaccine, but it needs, again, they need to be involved in making sure that they've had the booster. When you combine the UK and US experience, there are no safety concerns with vaccination. When you look at the Delta phase of the virus, which is perhaps the riskiest phase that's come through so far, for pregnant women, they were largely unvaccinated when Delta hit this country. And we had 10% of our admissions requiring ITU. We had an increase in maternal deaths. We had an increase in prematurity. And we had a significant increase in the rate of pneumonia. And a recent Rcog survey showed that 58% had not taken the vaccine early on. But now things are different. The booster vaccine is widespread. Currently, about 48% of women have been vaccinated at birth, and that's really good. Early on, it was only in the 20%. But certainly the effects of Omicron are significantly less severe, which is very good news. Now, the later needs. Now, this is all about the future. Where are we going in the future? And that's all post-pandemic planning. In the UK, and I know around the world, people waiting for surgery are increasing. And so the health systems around the world have to have a balanced and concerted effort to make sure the backlog is reduced. But we have to recognise that the staff have worked really hard and need of rest and need of support, and we need to support each other. And so that needs a national ambition and needs national investment. So what is next? Well, I think first, before we can fix things, we have to have a very good understanding of how coronavirus has affected our health systems around the world. We need to reprioritize the efforts, and we need to influence work in response to what needs to be done. But also we need to understand the effect on women. I'm a president of a college that looks after the doctors who care for women. And so we need to see what effect has this had on women. But we also need to plan largely for living with COVID and learn and prepare and plan better for future pandemics. So this is an opportunity. The pandemic has provided an opportunity, I think, that there are long-standing issues globally with women's health. We should look at the effect on the pandemic and make the way we look after women in the future better, not just recovering from the pandemic, but better when the pandemic is considered history. This in the UK has been an enormous team effort. I'm not going to go through all these societies that have helped me, but nonetheless, they have helped the Rcog, they've helped women, and we are incredibly grateful for their collaboration with the Rcog to guide women and doctors through the pandemic. Now, this is my office at the Rcog, where I would have spent many hours during the pandemic. During my presidency, but actually during the pandemic, this is where I spent a lot of hours in my home office here in Norfolk in the UK. It's a great office to work in, don't get me wrong, but I would have much rather been in London. I'm now back at London, half of the week, which is great. And if you come to the college, we would absolutely love to see you. The college is the most amazing place. I'm so pleased that now we're seeing ceremonies. This is a virtual ceremony from January 2021. So in January 2021, we felt we had to admit some new fellows and members who passed the exam digitally. And it was a wonderful ceremony, but of course, there was no one physical in the room except the officers and myself. And so we've now had some proper recent admission ceremonies. So I wear a mask until I get onto the stage. They are socially distant ceremonies and people wear a mask if they wish. But obviously I don't wear a mask when I'm giving my presidential address. So if you've recently passed your membership or you've been awarded a fellowship, then please do come to Union Street. This is our brand new building and we're so excited to have you thinking about coming. This was me in the atrium at Union Street, where I recorded my address for the Congress. And you will see that our amazing architecture of our new building. And again, this is in the southeast of London. It's in the most amazingly active part of the city. And so you would be very welcome to come and see us. This is what it looks like from the outside. It's a great place to be, and I hope that you will come. These were the gates of the college. I photographed them when they were closed as we left at the start of the pandemic. The gates are open again. You are most welcome to come. And I hope you've enjoyed this talk. I'm sorry I won't be there to answer any questions. I really hope I can come to your country and share the experiences of the UK and our learning from the pandemic in greater detail. Thank you very much. I hope you have enjoyed this presentation and I also hope you enjoy the rest of the conference. Thank you very much.
Thank you, Professor Edward Morris. We're really grateful for your comprehensive talk and the role the Royal College has played in this pandemic. And we in Pakistan, the Society of Obs and Gynae, has actually benefited from the RCOG guidelines greatly. So I will now request our panelists, Professor Shamma Munim and Professor Shahina Ishtiaq Zahur, to conclude this session with their final remarks. Thank you.
I'm really thankful to Dr. Acharya and bundle of thanks and appreciation for her enlightening us about the pathways for training in UK. And her talk has answered a lot of queries and questions which were there in the mind of our audiences about the MTI scheme and other pathways for learning and training in RCOG and in UK. I hope the audience, the trainees who are there, must have enjoyed her lecture. It was a very crisp and comprehensive talk. And thanks again from all of us. Thank you.
Mr. Morris, President RCOG, elaborated the role of RCOG in terms of support during the COVID and how COVID pandemic has changed many of the things for us. And the things that he highlighted were the role of RCOG in developing guidelines, patient information, and advocacy of all these things in the better preparation for against the COVID, and then in the restoration phase, how things are getting back to normal, and yet the RCOG has taken a proactive role in the development of vaccines, and in addition has actually worked in the forefront of arranging virtual meetings and conferences, and overall has had a meaningful impact for all of us using these resources. Thank you very much.
Thank you. So we conclude the session today. This hall is going to be, yes, you have a question, Dr. Fatma?
So it was a great presentation by Dr. Acharya. And my question was that, is it possible for someone who has passed PLAB 1 and 2 and has completed the equivalent of F1 as house job in Pakistan to directly apply for ST1 level jobs, or does F2 level job need to be there before ST1?
She was very helpful. I don't think it should be a problem, but I'm not the authority here. Right. So it would be, she's given her contacts and everything at the, they're very good with the Royal Colleges. If you drop them an email, they will reply to you.
Okay.
And we plan to have a follow-up meeting. They've offered that they want to, she's been trying to meet the fellows and members and trainees of Pakistan. So she really, and I just spoke to her. So we will have another session on Zoom and we will invite everybody.
Thank you.
So you can be part of that.
Thank you. It's great.
So we have to vacate this hall now for the inaugural ceremony, which will start at, the guests will be seated at 6:30 p.m. The minister, Dr. Azra Fazal Pecho, will be here in person. So, and she's very punctual. So I will request all of you to be here. Thank you very much. Thank you.